the 4 to 5 days to full compensation, for example, that we were talking about. Meanwhile, the protons, they have to go out. And here we acidify the urine. Now, how can protons go out? Well, some of the potassium is going to be excreted, but some of the potassium is actually going to be exchanged with the proton by H plus K plus ATPase. So look, it means when there's aldosterone, there's more potassium in the lumen, which means it will help potassium proton exchange and therefore promote metabolic alkalosis. You understand how aldosterone promotes metabolic alkalosis? Is that okay? Yeah? Look at another possibility. So here I'm going to say, note how aldosterone promotes metabolic more H plus K plus ATPase. There we go. The other possibility is for protons to come out with the chloride. And now you have chloride out here at the same time. So how am I going to excrete the acid that I produced? Well, in the proximal tubule, there is an enzyme called glutaminase, which is going to take the actual glutamine and is going to release some ammonia. And when you combine all these together, you're going to get ammonium chloride. That's called non-titratable acid. And that is the most important form of acid that we output. It's ammonium chloride. The other third is going to be with phosphate. And then it'll be phosphoric acid. And that's called titratable acid. And titratable acid is the other third of the acid output. So the way we're going to pee out our proton is as primarily ammonium chloride and some phosphoric acid. And phosphate and ammonia were just produced or released from the PTH, makes you trash some of the phosphate, and then you'll trash it as phosphoric acid. Well, what is a urine anion gap? In a urine anion gap, what do I find? Well, there's going to be very little sodium. There's little sodium because 99% is reabsorbed. But rather, there's lots of potassium from aldosterone. So potassium is your main cation. There's little bicarb, virtually all reabsorbed. But there is lots of chloride from non-titratable acid. So potassium minus chloride, that's the urine anion gap. So there's no bicarb, no sodium in the equation. And what do you think should be the sign? Look at the sign. What should we excrete more, potassium or chloride? What would you say? What should you have the most of in your urine? More potassium or more chloride? Remember, chloride comes as ammonium chloride, which is our major acid output. Right? So by far, we tend to have much more chloride in the urine than we have potassium. Absolutely, Donald. Absolutely, Maria. Zaire, you okay with that? So normal is negative. More chloride than potassium. And if there is any acidosis except one, except RTA1, and I'll explain to you in 1 second. If there is any acidosis, expect even more ammonium chloride production and excretion. So urine anion gap is very negative in acidotic state. Well, look, in RTA1, which is distal, it's a failure of intercalated cells. Less ammonium chloride produced. There's less protons to exchange with potassium. So increase potassium wasting. It's gonna cause a positive urine anion gap, which is gonna be diagnostic. Look, that's in RTA1. In my question, we had a problem with the proximal tubule. So a positive urine anion gap, it would always be as intercalated cell excrete more protons as ammonium chloride. The only time it would be positive is only if RTA type 1. Are you okay now with the urine anion gap and how it works? Now notice if there's a failure of these cells of working, of course there's acidosis, but of course there's also hyperchloremia. So tell me, what is again the serum anion gap of an RTA type 2? An RTA type 1 here, sorry, a distal RTA. What would be the serum anion gap? If my intercalated cells fail to make bicarb, they also fail to release chloride. You realize that with hyperchloremia and low bicarb, your serum anion gap would again be normal, showing you that RTAs, they always have a normal serum anion gap. The only place that's not tubular as a damage where there's a normal serum anion gap is when you have diarrhea. Anything that causes diarrhea is going to cause a very similar picture, because in the gut also, when we retain bicarb, is against chloride, so that every time diarrhea washes out the bicarb that was released by the pancreas in the small intestine, chloride is not exchanged anymore against the bicarb, so there's a hyperchloremic metabolic acidosis, hence a normal serum anion gap. Virtually all other metabolic acidoses, if it's not RTA or diarrhea, and RTA can be due to any cause you can come up with that would damage a segment of kidney tubule, well, then you would have an increased serum anion gap. So serum anion gap is very neat to show you RTAs or diarrhea versus the actual regular metabolic acidosis. So here we have increased serum anion gap metabolic acidosis, whereas here we have no change in serum anion gap metabolic acidosis, and that's going to be the RTAs 1, 2, and 4. There's no RTA 3, and it's also going to be any issue with diarrhea. Diarrhea is going to cause also a normal serum anion gap because of the hyperchloremia that comes with it. Well, hopefully that's going to have, with that one question, help you understand better both the proximal tubular function there and the intercalated cells and how we measure the acid output and urine anion gap. You okay with this one? Shall we do one different type of question? We try another one? All right. So let me make a different question. Since we were just looking at the proximal tubule,